Hi, everyone. It's Stephanie with the Patient Story, and I am so thrilled to have our guest for today, Dr. Farrukh Awan with UT Southwestern. Thank you so much for joining us today.
Thank you for having me. I look forward to this.
Yeah, it's going to be a great conversation, packed with so much information. And I know you specialize in bone marrow transplantation and treatments for leukemia and lymphoma there at UT Southwestern. We'd love to learn more about you, though, and what gets you excited, to get out of bed, to work on and study for the day. So can you give us a little overview?
Sure. So I've always been interested in studying the leukemias and lymphomas, studying the cancer biology. How does the cancer become resistant? What can we do to overcome that? How can we eliminate the cancer cells and, basically effectively cure our patients? So developing new drugs is part of that, being a part of those efforts, trying new drugs, combining it with one or the other options that we have already available, studying the side effects, managing the side effects. I think those are the kind of things that I feel are important. And in my small way, I can impact the field and slowly move the field forward. And that will happen one patient at a time. And the idea is to help as many people as we can.
Perfect. And without getting into the details, because we will tackle these different studies that you're a part of one by one, but if you were to give an overview, a lay of the land to new patients and caregivers about how quickly treatments are moving, new therapies, where we are in the last 5 years, 10 years when it comes to this for leukemias and lymphomas, how would you describe that?
So I'm primarily a leukemia doctor and a lymphoma doctor. So I basically focus on lymph node cancers. And if there's a leukemic version of the lymph node cancers, those are my areas of expertise. And I can tell you that there's 80 different types of cancer in that group, at least 80, maybe more. And within those 80 diagnoses, there are more subtypes in those groups. So it's not one cancer. That's the first thing to remember. It's a family of cancers, and every cancer has a different name. Every cancer has a different subtype. Every subtype is treated differently, is managed differently. So just saying that you have lymphoma narrows the diagnosis down to maybe 80 different options. Even if you say a non-Hodgkin lymphoma, that narrows it down to 75 different options. So, it really is a very, very complicated, very broad field. So we have a lot of patients who get these cancers, but fortunately, it's not as common as breast cancer or lung cancer. Those are more common than lymphoma. So we don't have as many patients as the more common cancers, but we still have a fair number of patients who are living afterwards, after they've been cured, after they've been treated, or in remission. So we have a lot of people who've been exposed to this cancer, who are dealing with this cancer, and are survivors of this cancer. So we have a fair number of those patients. Just within the lymphoma field, there has been a significant increase in the number of new drugs that have been approved over the last few years. Even in the last 2 or 3 years, it's at least 5 or 6 new drugs. But then it also depends on what subtype you're looking at. If you're looking at large cell lymphoma, there's a whole slew of drugs that were approved for that. If you're looking at second line large cell, third line treatment, fourth line treatment, there are drugs in every spot which were approved. Then if you're looking at follicular lymphoma, there are drugs approved for that. If you're looking at marginal zone lymphoma, and so on and so forth. If you're looking at CLL, there's so many new options. So the point is that if you look at the whole lymphoma family as a whole, there would be probably 15 to 20 new drugs. And if you look at the individual subsets, every subset has some new option or multiple new options in the last few years, which is really impacting the outcome of our patients. It's getting better and better every day. And patients have more choices now, which also basically puts us in a tricky spot as physicians, because now sequencing becomes a big question mark. Which one should we do first? Which one should we do second? What's the pros? What's the con? Which is curative, which is not? So as our options are increasing, our ability to give it to our patients is also improving, but it also makes it more nebulous because we don't know what the right sequence is, and nobody does. So it's a lot of opinion, it's a lot of early data, and this is exactly why we need clinical trials, because that's the only way we can answer what is the right sequence of events, how should we do this, so we can eventually cure everyone without having to use chemotherapy ever again.
That's music to my ears. I'm, secretly, not so secretly, also really excited about this conversation because my diagnosis specifically had changed, but originally it was DLBCL with double expressor, and I went through dose-adjusted R-EPOCH, and that was not fun, to say the least. And so, hearing about all these options, and I know it's like you pointed out, it's specific to very, to subtypes and different, like first line, second line, third line. There are a lot of details involved. It's still just really exciting to know that there's so much progression happening when it comes to these discoveries. So without further ado, let's dive into that. So Dr. Awan, I know you're involved with several different clinical trials, must keep you really busy. Let's talk about the first one. People may not know that much about, but it's venetoclax-selinexor. So can you just describe what that trial is, whom it's for, and then we'll go from there.
So this particular trial is for patients who have failed frontline treatment or have failed at least one prior treatment for their lymphomas, and or if they don't have any other option in the opinion of the investigator, if they're not candidates for other options, so they can go on this trial. So this trial is also for patients who have failed treatment for acute leukemia. So it has both groups of patients that are eligible to get these drugs. So what are these drugs? So selinexor and venetoclax are both pills that can be taken, and they are not your conventional chemotherapy options. They work very nicely, and they basically are designed to turn off the factory inside the cancer cell, which makes the products that keeps the cancer cell growing over and over again. So essentially, the selinexor goes inside the factory and blocks any production from the factory from coming out of the factory. So basically, the cells then die of the stress because the factory is not making all the stuff that it's supposed to. Similarly, the BCL2 inhibitor or venetoclax, this is a medicine that is designed to turn off the energy generator of the body or of the cell, of the cancer cell. It basically goes in and turns it off. And once you don't have any energy source happening, the cancer cell just basically dies. So these are very nice and very targeted options, which are very promising. They are already approved in various indications for other cancers. And this is the first time that it's been combined like this together in lymphomas and leukemias. And the idea is to turn off the cancer cells and to minimize damage to the normal cells.
Perfect. That was, I could understand that. Thank you very much. So what do the patients there at UT Southwestern go through in terms of the regimen? And then we'll go into, of course, side effects and management after that.
Yeah, that's a great question. So it's not just this trial, but for any trial, I think the biggest thing that I would like to stress is to have a discussion with your physician. We need to lay down all the options on a piece of paper, trial options and non-trial options, the options that are available right now, standard of care options. And then we need to go through trial by trial and option by option to really see where it fits with the patient's state and stage of the disease and the side effects and the patient issues. Maybe the patient has heart disease or lung disease or kidney disease, diabetes, hypertension. All those factors are important. So it's a marriage of patient preferences and the options that the doctor gives you. There is no one size fits all. For my patients, it's always an ongoing discussion. Once we decide, okay, fine, these are our one or two options, we narrow it down, we talk about the pros and cons. Ultimately, the patients are not trained to make that decision. We as physicians are trained to help them make that decision. So my job is to help them make a decision that they will be comfortable with, and that there won't be any regrets later on that I should have done this or I should have done that. I think that is really the key. And I think that establishes a trust with my patient, and I need to help them make that decision for themselves, which they are comfortable with. So we look at all the factors that we have. I then give them the pros and cons of everything, and then I ask them to go home. I even give them the consent form sometime of the clinical trials, and I give them reading material or educational material on the drugs that we are talking about if it's the standard of care. And I say, you know what, you need to go home, you need to sleep over it, and then tell me what you want to do tomorrow or day after, because I don't want you to make a decision on the spot, because these are difficult decisions, and maybe they would like to get another opinion. Maybe they would like to talk to their family before they make that decision. These are all factors that go into making a decision. And once the patient is satisfied that this is the right thing, we discuss again, and then we start. Every trial has what we call a screening process. So basically, you have to go through a battery of tests to make sure that you're eligible. For example, is the patient 18 years of age? Is the patient able to understand? Are they able to swallow pills and so on? Is the female pregnant or not? All of those factors, I need to check off all the boxes. Kidneys are good, liver is good, whatever the requirement is for that particular trial. And then we get all of that fact together. And then if the patient qualifies, then we come up with a start date. And most of these trials need scans and biopsies and so on. So it just depends on the kind of trial that you're looking at. But basically, that's roughly the process from start to finish. Depending on the trial, it can take 2 to 3 days, 5 days. Sometimes it can take 4 weeks. But usually it's in between 1 to 2 to 3 weeks that we can start and then get the patient started on a trial. Now, in some cases, obviously, if the disease is very aggressive, we would have to move early, and those are unique situations, and we have to deal with those situations. But for the most part, it takes around 2 to 3 weeks to get on a trial.
Perfect. I'm so glad you brought up some of these things, because I was going to ask you about the shared sort of treatment decision-making process. You went through that, what you do, and what I'm hearing from you is it's a balance. It's, look, I'm trained in this. It's my job to translate what this means, help guide you, but you also want the patients to be able to have the time and the knowledge to make their own decisions. Is that right?
Oh, absolutely. Because I think if the patient is satisfied, if the patient is compliant, it makes it so much easier to take care of them. If they trust you, I think that is really the key for me. I would want to trust my physician if I was in their situation. And if there's any doubt, if there's any shred of second guesses, I always feel that you need to address that, because I feel that the regret of commission is less than the regret of omission. So you have to do that stuff and address these issues before you get started on any treatment. It doesn't matter if it's a clinical trial. It can be standard R-CHOP chemotherapy, or, like you said, R-EPOCH chemotherapy. I think if the patient is comfortable with the plan, you will always have better outcomes. You will have more compliant patients. You will have a good relationship with your patients. They trust you. You trust them to show up on certain days and do things like you want to be done. And I think that really is the key. It's a trust relationship at the end of the day. And if there's any problems with that, without fixing it, you will not have a healthy patient-provider relationship. And that's what it's all about, really, because we're not talking about 1 day or 2 day, I get a surgery done and move on. And as long as the healing is fine, I may not ever have to see the surgeon again. Our patients have to be seen on a weekly basis for months and months and months. Sometimes they're in the hospital for days and days. We develop a bond with our patients. So it's extremely important to start off on the right footing. So, and if that means getting a second opinion, by all means, whatever provides you peace of mind, that is the key. And that is really where I've spent the most time upfront, because I feel that that's an investment in that patient-provider relationship for me.
That's music to my ears, and I think a lot of patients' ears who might feel we have to be good patients and aren't really sure about that balance. So it's always great to hear when the physician is so pro empowered patient. So thank you for that. You brought something up that I do want to touch on. You said, and we can apply this to this specific trial with venetoclax and selinexor, but what would be the differences? Let's say you have a crowd of patients, a population, they all qualify for this specific trial, but what would the variables be that would edge you one way or the other to say, well, maybe you should consider this and maybe you shouldn't? Is it more like age? I'm talking sort of bigger picture here.
Yeah, so these are great questions. So all of the above: age, preference, response to prior chemotherapy. Maybe the patient is not a candidate for chemotherapy. I had a patient who did not want any chemotherapy. And I told him, historically, if I use chemotherapy, I can get you into a nice remission, and we can do a stem cell transplant. We can do cellular therapy, CAR T cells. And he was like, I would rather die than use chemotherapy. And why did he say that? Because his previous experience was horrific. He had chemotherapy, he had regular R-CHOP, and he had every single complication under the sun. He almost died during the complications. It was just very unfortunate. But he was so traumatized from that he was like, if I get chemo, I'm going to die. Or at least that's what he thinks. And I understand that's not accurate, but I respect his wishes. So I think if I had gone in the room and I said, sorry, the only key option you have is chemotherapy, then he probably would have found another doctor, which is exactly what happened with him. Actually, I was his third doctor because all of us kept saying the same thing. And nobody bothered to explore alternative options. Maybe there are non-chemotherapy options. And as it stands right now, 3-4 months into it, his cancer is almost gone. He's in a very good remission. And he is tolerating the drugs very well. So this is just an example that none of us know what the future holds. And there's no right or wrong thing in medicine. It's all relative. It's all very subjective. A lot of patients, you would expect them to do really well with EPOC and R-CHOP, but sometimes people really have bad side effects. Similarly, a lot of these newer drugs may not be as effective in some of those patients, but in some of those patients, you have, uh, you know, it's just difficult. It's hard to um, not use these other options in non-chemotherapy options because they might be just as effective as chemotherapy. Because that's why we're doing the trial. If we knew what was the best option, we would stop doing trials and everybody would be cured all the time. But I think that's the goal. We want to cure 100% of patients with 0% toxicity. And I think that's the utopian goal. And until we get to that 100% efficacy and 0% toxicity, I think we should keep treating patients on trials. And the closer we get to that goal, I think the better it is. Until we are there, if you have the technology where we can zap somebody for 1 second and fix everything in their body, until we are there, I think we should keep trying to get as good in our care as possible and help as many people as we can. So the point is, every patient is different. I think it's a discussion, and you have to keep your mind open when you talk about it and explore all the options and see which one fits the best.
Wonderfully put. And of course, this is, like you said, it comes down to just sort of getting more information that benefits everybody in this case. So on that note, then let's talk just a couple more questions on this particular trial before we move on to the next. What is I know it's studying this phase 1 study of the dose of the side effects. So what can you tell us about what you've been able to see? And, you said these are oral pills. How often are people taking it? And for how long?
So yeah, it's early days right now to really see for sure what's going to happen with it, but I've seen some promising results so far. We have also seen that the drugs are reasonably well tolerated. Both the drugs, we have a lot of experience with selinexor. We also have a lot of experience with venetoclax in other diseases. So these are not new drugs for us. We know what the side effects can be, what to expect, how to manage them properly. So we're seeing mostly the similar type of side effects. And that's exactly why the study is being done. How much can the patients handle? What kind of dose can we give? How can we best manage those patients? So I think it's a work in progress. So far, so good. Looks nice. But we need more data and more results before we can conclusively say what dose would be the maximum dose or the safest dose at which we see the best outcome. And then that's how we will then lead to the second phase. Once we've established a dose, we will say, okay, fine, this is what we think is the most optimum dose. And then we will treat more patients to really give an exact idea of what the benefit is. Because right now, managing the side effects and establishing the dose is the key. But the next step is to really look at what the benefit would be if we treat a larger number, let's say 20 or 40 patients with the same regimen. I think that's the part 2 of the study, which we're getting close to.
And, I don't know how much you can disclose, but people are going to wonder too, like how big is the population? I know there are several different investigation sites, so it's not just at UT Southwestern, but are we talking like a couple dozen there, or is it a smaller group
It's a smaller group. Our colleagues in Vanderbilt lead the effort, and there are at least 4 other sites, if I'm not mistaken. So it's a very limited group of places where this particular trial is open.
Okay, and but at your particular site, it's like a handful of patients. Is that right? That are being studied?
Yes, it's a
Okay.
small number of patients, and that's how it happens in most phase 1 studies. It's 1 patient at a time, and then we enroll 3 patients, and then we make sure they do okay before we enroll more patients, because we don't want to have any unexpected side effect. We don't want any surprises. So we do one person at a time typically, or sometimes 2 patients at a time, but we stop after 3 patients, reassess, go up on the dose, go down on the dose, and adjust the plans accordingly. So it's a 3+3 standard phase 1 design, where we treat 3 patients in 1 dose and then go up or down, depending on what happens with those 3 patients.
Perfect. And are you there yet? Are you in the first 3 right now, or are you already in the?
No. We're actually getting close to the end, where we're very close to the maximum dose level that we had thought would be the maximum that we would like to go to.
Okay.
So we're very close. So I think we are all getting really good doses. All our patients are getting very effective doses already.
Perfect. One of my last questions here is, I know with side effects, they vary person to person. That's part of the study. But what kinds are we talking about here? I think there's such a gamut of side effects. So what can you say about what are the most common ones and how to manage them?
So again, we have a lot of experience with selinexor. We have a lot of experience with venetoclax. With selinexor, we see nausea, weight loss, just don't have an appetite. There are ways to manage that. There are ways that we can do appetite stimulants, which are helpful for the patients. So that's the thing with selinexor. It can also cause some blood counts to be on the lower side. So we might have to give growth factors for that, and blood transfusion for that. Similarly, venetoclax, we've had a long experience with that. We've used it in a lot of other diseases. Similar to that, it causes some occasional diarrhea, and venetoclax also causes a drop in the blood counts too. So I think those are kind of the side effects that we have, we know with these 2 drugs, and that's what we are looking for and managing it appropriately. But no problem so far. So far, so good. Nothing unexpected.
Wonderful. Okay, so we'll keep updated with you on how this all goes and stay in touch. But let's move on to a very exciting study, the BITE study, which has a lot of possibilities here. And so I'd love for you to just break it down. What is the study focused on, and who is it for?
So there are multiple BITEs. So BITEs are a group of compounds which are basically called bispecific T-cell engagers. So it's not just one BITE. There's multiple BITEs out there, and we are participating in, I think, 3 or 4 of them across all different types of cancers. And basically what they're doing is they are identifying a spot on the cancer cell. They're targeting that spot and kind of latches on to that cancer cell. And while they do that, they also engage the policemen, which are in the body, the lymphocytes or the killer cells, the natural cells, the natural killer cells, the natural lymphocytes. And what they do is they bring the killer cell or the policeman close to where the bad guy is. And at the same time, they're stimulating the policeman. Hey, this is the bad guy. I want you to kill it. So that's what they're designed to do. So they're designed to attract these 2 cells. And the idea is that the cancer cell will die because it's in close proximity to an activated T cell or a natural killer cell. So there are multiple BITEs that are in clinical trials, and there's a lot of excitement around them. They're targeting different things on the cancer cells, which we call antigens. So they're targeting CD19, CD20, CD37, and so on. So there's multiple such options available for acute leukemias, for lymphomas, for chronic leukemias. So I think that's very exciting because that's a little bit different from CAR T cells, which are also very popular. And in the CAR T cells, what we do is we take the same policemen out of the body, we give them new guns, we expand them, and then we give it back to the patient, and those CAR T cells then find the cancer cells and kill them. In the BITEs, everything's happening in the body. So obviously convenience is a significant issue, significantly better with those agents. You don't have to wait for the manufacturing of the CAR Ts. So I think it has its advantages. And again, we just have to see how it pans out, what the right doses are, how to dose them, how often to dose it, what are the side effects, and so on and so forth. So I think it's a step in the right direction. This technology is not new. It's been around for a while. And we have blinatumomab that's already approved for ALL patients. We've used that a lot in the past, and we've used multiple other bites over the years, but it's getting better and better. Toxicity, side effects are getting easier to manage. The way we give it, we used to give it continuously 24/7 in the past. Now we can just do it once a week. Sometimes we can do under the skin shots. So there's so many new exciting things happening with the way we manufacture these products and give it to our patients.
So where are you with I know you're involved, UT Southwestern's involved, you said, in several of these, but you in particular, where is that study, and how close are we to seeing it being able to be used, in different places?
So we are part of the GenMab BITE trials. We're also part of the Regeneron BITE trials. We have both the CD19 and the CD20 and the CD37 BITEs. So we have multiple BITEs. Most of them are in the phase 1 and phase 2 expansion phases. So basically, we are still trying to identify the optimum dose, and then the next step is to really look at the benefit in a larger cohort of patients. So we, again, like I said, we have multiple options at our site specifically for a lot of lymphoid malignancies or a lot of lymphomas. And then we can do different formulations targeting different things.
Perfect. So let's say, I know this is still in phase 1, phase 2, a lot of these, but let's just say that it's approved. Okay, so we're fast forwarding to the future. I'm a new patient of yours, Dr. Awan. I walk into your office. I'm like, I qualify for this. What would it look like for me, this treatment? What would my life look like? Is it, okay, once I'm on it, I would be going in once a week. It could be a subcutaneous shot. It could be like just trying to understand in human terms what that treatment is.
Sure. I think at this point, yes, we have the once a week IV shot. And then we also have similarly once a week under the skin shot. I have patients on both those trials. It just depends on the specific situation for that particular patient. But yeah, it's literally that. Because these are relatively new drugs, some of those patients we might admit to the hospital for 24 hours for observation after they get the shot. But in the future, we may not even have to do that once we see how the side effects are. And it essentially can be continued until you have either a disease response or until you know for sure that it's not working. So it's getting very convenient. It's literally a weekly shot.
You actually did answer my next question a bit in there, where it's like, I was wondering how long would I be on this shot or IV infusion? And you're saying we could take weeks, it could take months, depending on the person. It's really the response, the individual response.
Yeah, so you can obviously, if you have progressive disease, then there's no point in continuing that. If you have side effects, then obviously you can stop it at any time, but you can potentially continue it as long as you need to, as long as it works.
I'm curious too, just because BITE, CAR T, I know they've been around, but a lot of people are not as familiar with them. So Dr. Awan, if someone were to not have BITE work on them, is CAR T still a possibility and vice versa? Or, just curious about the sort of treatment options here.
Yeah, so CAR Ts have been approved for large cell lymphoma for a couple of years now. And we have 3 different approved options, which are what we call autologous CAR T cells. So basically in those, what happens is that you take the patient's own policemen or lymphocytes basically, and then send them out to a manufacturing facility, wherever that factory is. And that factory takes around 3 weeks or so to manufacture the cells, expand the cells, literally give the policemen new guns, new bullets, and a shiny armor. And then basically you get the cells back in a small vial, and then you infuse it into the patient. So CAR T cells then go inside the body and then find the cancer cell and kill it. So CAR T cells have been around for a while now, and they've been approved for a couple of years. And we are using it very often on our patients on the commercial side as standard of care procedures. And we've had very promising results. and probably 50% of the patients, around 40 to 50% of the patients are cured by those things. It's very, very promising. And these are patients who historically had no options. So this has been a major advance in the field. Now we actually have another trial open of what we call allogeneic CAR T cells, in which what happens is that rather than taking the cells out from the patient's own body, these are normal donor cells which have been selected. So they are not going to fight the patient's body, but they will fight only the patient's cancer cells. And those have been manufactured already and they're in vials. So if I say, I need to go tomorrow, they say, okay, fine, here's the vial. We give you the vial, and it does the same thing as the autologous CAR T cells. The allogeneic CAR T trials that we have are very exciting. We've actually treated a few patients on that, and it's looking very promising. There's a lot of excitement in the field about how this will pan out. And that will actually cut down on the 3-week or 4-week waiting time for while you're waiting to get the cells manufactured. So if you wanted to do a CAR T tomorrow, you could do it tomorrow, or in a few days, because it's really very simple. And that will probably also bring the cost down at some point in time. So the point is that there's a lot of new things that are happening in the CAR T field, and it's looking very promising. They are a little bit more established than the BiTEs, but the BiTEs are also looking very promising. So at this point, there's no right or wrong answer of what you would use.
Perfect. It's just there are more options. And as you had said earlier in our conversation, this is something that physicians are having to work out as well, right? It's very individual and it's okay. Lastly, about these particular two treatments and options, with side effects, what should people just sort of know about them? I know that, again, there's a whole range of them and it depends on the person, but is it similar in what you've seen so far in terms of side effects and management between, say, BiTE and CAR T, or are they very different?
So both the BiTEs and CAR Ts, at the heart of it, they have similar function. And that really is to activate your immune system or to use activated immune cells. Those are the lymphocytes that are manufactured and engineered. So anytime you activate the immune system, you will have inflammation in the body. And that inflammation can cause side effects. And what are those side effects? That can be rash, that can be fevers, that can be shakes and chills, and that could be low blood pressure. So those are called cytokine release syndrome, or in which you have a really huge inflammatory response, and the body doesn't like it at all when the lymphocytes or the immune system is activated. So this is a natural response of the body, and cytokine release is seen in both the BiTEs and the CAR Ts, and that really is one of the major side effects. That's why a lot of times we need to admit the patients to the hospital to monitor them for that in the first few days of getting the drug as the immune system is being activated. So that's the first thing. Second thing is we can also have what we call neurotoxicity, because again, from that inflammation that's happening at such a high rate and at a rapid inflammatory response, you get some inflammation and swelling in and around the brain tissue, and you can have some problems related to that. You can have some seizures, you can have some confusion, some headaches, and so on. But typically all of those side effects are mild and manageable and very reversible. A lot of patients have those, but it's also usually a low grade side effect. For example, a lot of my patients will have a little bit of fever for a few days, maybe some low blood pressure, but nothing major. Some people can have some confusion, but otherwise they don't have any issues. Occasionally, you might have somebody who might have a seizure problem. So this is exactly why it's important to get consultation with an expert in the field who have done a bunch of these, who has a team that is available to help him through that process like we do. We have a whole team of people. When the patient gets admitted, they need to be seen by the kidney doctors, they need to be seen by the heart doctors. They have the neurology doctors ready to help them with any complications. So it's a team effort. The nurses are trained in the CAR T side effects. And if it goes well, they can be out of the hospital very soon. And if it doesn't, if they have a side effects, we manage it and we reverse it. So the point is that, yes, it sounds scary with the side effects, but the fact is that the mortality or the risk of dying is very, very small, number one. And the risk of chances of recovery are very good, even if you have a side effect. And the vast majority of people have a mild side effect, which can be easily managed. So I think, and then on the flip side, you have roughly 50% chance of being cured, which is pretty good. I'll take it. So I think that's why this has been such a big advance in the field in terms of CAR T. Bites are relatively new. We need more evidence about them, but they can potentially do the same thing. We just need more data.
And I know you're collecting that data, and we will again keep, everyone posted via Dr. Awan on the progress there. My last question for you is just overall, you've done a great job explaining the trials you're a part of now. But overall, what is your feeling, level of excitement about current and near future therapies and treatments when it comes to, your areas of study, which I know can be broad, but overall?
So I think we're all very excited about all of these new treatments. I think there's a few themes, a few trends that are very clear now. The field is moving away from chemotherapy. Slowly and gradually, we are chipping away at it. But like you mentioned before, drugs like R-CHOP, R-EPOC, combinations like that, or bendamustine, they've established such a high bar that it's very hard to challenge them. But we have to keep challenging them. We have to keep pushing it. We have to keep using all of these new drugs in an effort to try to overcome any challenges or problems with these old drugs and move away from chemotherapy. So I think that's the most exciting thing that's happening in the field. The second most important thing that I would like to talk about is the fact that despite the fact that all of these resources are available, and we are potentially talking about curing half of our patients, even in the worst case scenario, and maybe a lot more in the best case scenario, it's a small fraction of percentage of patients that are actually getting access to these resources, which is, I feel, it's unfortunate in this country, but the percentage of patients who should be candidates for CAR T cells are much higher than the number of percentage of patients who actually make it to CAR T cells. So what's happening with those patients? They're not being referred, they're not being offered, they're not, the doctors are not telling them. Remember, it's not the patient's job to know about all of these things. It's a doctor's job to educate them. And some of the doctors may not know because they're not necessarily in big towns where they have access to these resources. So my suggestion is please always ask for a clinical trial. Please ask for a second opinion to a referral center or a specialized center, because even if they don't disagree with the management that you are undergoing, the treatment that you're undergoing, you might find additional options. It's always good to get that second opinion from a place that specializes in that field, because you can always get the best and the latest. And then, yeah, if they say, fine, just continue with our job close to home, that's perfectly reasonable. But now at least you know where to go if you have any questions. If the cancer comes back and if you have a problem, you can potentially be candidate for other newer treatment options. So there's so many things that can happen if you have the right consultation. So I strongly urge patients to please get a second opinion. Please get an opinion from the lymphoma specialist, which is close to you. And nowadays, with the COVID restrictions, we've had ample time to figure out how to help patients who may not be able to come in person to our center. And that's why I think it's really important for patients to make that extra effort to reach out, and then we can even reach them remotely. Because I think that's the only way to make this thing accessible to everyone in this country and not just a select group of patients who have access to those resources very easily.
Absolutely. One of the few benefits of having the COVID situation happen was just the emphasis on telemedicine and remote access. And like you said, that access is so key to address so many things, including healthcare inequities and people in rural areas who might not be right there where UT Southwestern is. And on that note, if people are interested, they love your conversation, your style, Dr. Awan, can they reach out to you? Can they how do they get in touch with you?
Sure, absolutely. Feel free to reach out via email. That's the best way to get in touch with me. It's my first name dot last name at utsouthwestern.edu. So Farrukh.Awan at utsouthwestern.edu. Please feel free to reach out, and I would love to get back to you and help you in whatever way I can.
Perfect. And we will have all of that along with this conversation, the video, the transcript, the full story with Dr. Awan at thepatientstory.com. So again, Dr. Awan, super appreciate your time today. It was incredibly educational for me, I know for our audience, and I look forward to talking to you again.
Thank you. I really enjoyed it.
And everyone, again, you'll find Dr. Farrukh Awan's conversation with me at thepatientstory.com, where we give human answers to your cancer questions.